to everyone, and hearty congratulations to the organizers for this very beautiful flow of scientific content. I was really happy to see the agenda, and thanks for having me as a part of your endeavor, which is going to get bigger and bigger with the coming years. So, congratulations again, and thank you. Um, Before we move on with this particular session, that is CAR T cell therapy, I have to give this disclaimer that I have no experience of having done one or handled one, although I work with in very close association with people who have done CAR T cell therapies from University of Toronto and also from Philadelphia. And I will be shortly going on for an internship and training at St. Louis Hospital, Paris, for the same. Because my hospital is also gearing up for this, likely by December, Jan is what we are looking at. But of course, it's currently exuberantly expensive and correct patient selection is paramount. So we're just still working on that. Before moving on, I would like to know how many in the audience are intensivists? Because I'm scared of talking to oncologists. Thank you. So, yeah. Oops. No, but they're chairperson, so I have an excuse. Yeah. So kindly excuse if I, blurt out something out of my sheer ignorance. Okay, so CAR T, I mean, it's just expanded. It's something new to me also. Although we've been reading about it, we've been writing a couple of things. I'm part of coordinating a particular trial also. I'm more of a technical person in that, not the clinician. It's expanded as chimeric antigen receptor T cell therapy, okay? And it is appearing to be a very, very promising form of therapy, especially for relapsing and refractory lymphomas and leukemias, especially B cell lymphomas and leukemias at this time point, to some extent multiple myelomas also. But there's so much of media hype that's been created already, especially after President Murmu announces that India is all set to go ahead with CAR T cell therapy. People come and walk in asking for CAR T cell therapy as a first line. That's not how it works. All right. So when we say chimeric, that's basically something that's born out of genetic modification or genetic engineering. So what happens is here, if this cursor is seen over there. So the process starts off with basically leukapheresis. So it's an autologous process. The person's own T cells are harvested. Now that again, so every step in this process is enormously cumbersome. Okay, because timing the leukapheresis to chemotherapy or maybe radiotherapy or intercurrent infections, illness is very, very important. So there is a leukapheresis that happens, and again the yield also is going to be a little tricky. And then once you do the leukapheresis, that needs to be transported to the lab which is capable of doing this genetic engineering. Now, until now, it's been trans-border out of the country that you had to send if you were to have done a CAR T cell therapy. So it's going to go through all those rigorous testings that is required for trans-border shipment of human fluids or viable fluids, and it reaches the lab where it is genetically engineered during viral vectors. They induce these changes such that these T cells start producing receptors on their cell surface. Basically receptors that are capable of identifying the cancer antigens. These are then allowed to proliferate or multiply in a medium. This is again not a very easy process. And then after that, it is shipped back to the original unit where the patient is infused. Again, timing of infusion of these CAR T cells is also so very important because the patient could be sick at that time. He needs to be properly lymphodepleted and kept ready. He could be suffering from pancytopenias or maybe problems related to the chemotherapy that's used to induce the lymphodepletion, all those things. Even after infusion, it is quite possible that the infused cells may not proliferate or may not work good in vivo. Okay, so many issues are there, right? Of course, all this molecular part of it, I think we can skip for now in good interest of time. So from the historic approval of CAR T cell therapy by FDA way back in 2017, if I'm not wrong, all these, don't ask me to pronounce any of these, okay? All these CAR T constructs are now available and are FDA approved. There is a bigger list, which is probably approved by European Union and several other Chinese and Japanese products. So many again are there. Currently, there are around 70 centers in the US that are approved and that keep doing this CAR T cell. There are so many other centers in Europe. St. Louis Hospital, again, is one big center that has a very big database of from where a lot of evidence has been coming up these days. And India has not been too far away. In 2021, we had our first patient who was tested with our own indigenous construct, thanks to the efforts of Alka Dwivedi and Rahul Purwar from IIT Mumbai, who together with this organization, the Immuno Act, which is a sister concern of IIT Mumbai again, come up with this NextCar 19. So India is proudly in the map of countries that are capable of advanced genetic therapies, advanced cell therapies. And interestingly, this particular product, or this construct, they call it, has been shown to have a lot less, adverse effect profile compared to the ones that are available elsewhere. And in this, limited experience from TMC, we see a treatment response somewhere around 70% for leukemias and lymphomas again. Okay? And the incidence of adverse effects are also pretty less. And having this being engineered in India, you can imagine the cost is going to come down a lot. So what otherwise would cost you anywhere between 3 to 4 crores if you are going to ship it to US is expected to cost around somewhere like 30 to 40 lakhs, hopefully. Okay. So as much glamorous as it looks, it is not without problems. It is that much challenging, cumbersome, cost-consuming, whatever you call it. Like I told you, starting from the stage of harvesting, being able to proliferate, growing it in vitro, growing it in vivo. If it comes past all that and then you release it into the body, this is very notorious. You can see akin to bacterial infections, even the cancer cells can undergo immune modulation or downregulation of certain antigens that are expressed. So this whole process could become ineffective. And we know that as of now, this therapy is approved only for a small bunch of hematological malignancies. So solid malignancies, solid tumors are out of question. Several other brain-related tumors are out of question. But all that apart, where it makes a big implication for us is the incidence of toxicities. We've had so many lectures from the morning talking about chemo-related toxicities, immune therapy-related toxicities, targeted therapy-related toxicities. So again, we're going to be facing a whole bunch of toxicities. And this is a cute but complex mnemonic by Professor Eli Azouli, who heads the unit at St. Louis, Paris. Where he says, or where he tries to explain where the intensivist actually fits in. So the mnemonic is actually CAR T cells. I'm not going to elaborate on this. He feels, or it also appears, that we come into the picture right from the beginning, from the stage of counseling the patient for the therapy, wherein we get to something like, the prehabilitation that happens before surgeries. Okay, so you get to treat, optimize his comorbidities, do infection screening, get him better and prepared for the process, walk him through the plus or minus ICU stage and even beyond, because it's going to need a lot of follow-up. And he feels that intensivists should also be part of translational research, data sharing, and all that. Okay, so that's where we come around. But our role is going to be really big when they come into the ICU. Because, again, there are data from many of these centers, individual center data. I'm not going to be elaborating on each one of these because that way I'm going to be talking for at least an hour. But overall, it seems like at least anywhere between 30 to 50% of the patients who go through a CAR T cell therapy will land up in the ICU. Again, that's going to depend upon your threshold for ICU admission. If you land up admitting people with grade 1 toxicities also, you're probably going to have bigger incidence of ICU admissions. Okay, in the West, where they are crunch for ICU admissions, they start admitting only when it is well beyond grade 2 of toxicity. So from there is where we get this 15 to 47%. Again, it's a little different between pediatrics and adults, all those things. And the reason for ICU admission by and large is because of the toxicities, which are so very common. Certain unique toxicities, which I will briefly touch upon in the next few slides. And we're going to be handling a whole bunch of new drugs. Notably, the first line therapy happens to be tocilizumab. Luckily, we are all experts in tocilizumab thanks to the pandemic. In lines with toci, there is this cetuximab, anakinra, and of course corticosteroids. These are broadly the medical or the therapeutic armamentarium that's available to tackle these toxicities. And there are going to be a whole bunch of interactions, and the biggest problem for the intensivist in this context is going to be timing of EOL, because if you're going to be spending 30-40 lakhs on a patient for a certain therapy, and then there is this person either getting into grade 4 toxicity or becoming extremely sick because of disease progression, maybe you cannot really call. I know it's going to become very tricky labeling it as futile care at any time point if you have subjected somebody to such a therapy. And imagine the kind of media hype that is currently going on around. So that's going to be one big challenge. And these are all what we think of, or what we need to keep in the back of our mind when we get ourselves prepared for these sort of advanced therapies. And like I told you, there are different statistics coming all over the world from. I choose to keep referring to this St. Louis hospital, their experience of 166 patients over a 3 to 4 year period, wherein 71 out of the 166 landed up in the ICU. So that's roughly a mean ICU admission of 42%, mainly for these 4 reasons that you see over here. Predominantly the cytokine release syndrome, close to 46 or 45% of them had isolated CRS, whereas various other reasons also, like sepsis. In their case, it was mainly CLABSIs, undiagnosed query sepsis, query CRS sort of pictures, and also disease progression. You can see that, of course, the ICU admission rates are going to be different depending upon the kind of cancer. Likewise, the mortality also differs depending upon the kind of cancer. ICANS, that's another unique toxicity. That is basically the encephalopathy syndrome or the neurotoxicity syndrome, which is variably referred to as either ICANS, immune effector cell associated neurotoxicity syndrome, or also known as CRESS. Okay, that is CAR T related encephalopathy syndrome. So all of these can be the presenting reason for ICU admission at different frequencies. And I told you the NextCar 19 has a lot less incidence of such problems. So we really need to watch out. And what are these toxicities? I just gave you a big list of them. Unique toxicities starting from cytokine response syndrome, ICANS. The IEC-HS is basically HLH. Okay, I don't need to be expanding too much on HLH for you. Cytopenias, B-cell aplasias, there's a big list. Okay, it's going to be very difficult for us to dwell in each one of them. So for an intensivist, a dysregulated immune response or an exaggerated immune response is not something that is new to us. So when it goes well over and beyond what it is supposed to do, that's when we land up with these problems. So all these bunch of toxicities are related to immune exaggeration. When they start affecting the endothelial linings, when they start developing the capillary leak, or maybe when they start breaching the blood-brain barrier, when the effect extends on to neurological tissue, that's when we land up with all these toxicities. And I keep using the word unique toxicities because they have a characteristic presentation. And these are basically mediated by a whole bunch, more than 100 apparently, list of cytokines, chemokines, and all sorts of immune mediators of inflammation. And right now we have several working groups, but notably the CAR T cell related toxicity working group, which is a big consensus group that gives us recommendations and guidelines lately. But again, we need to remember that we are still evolving in this process. And you can really go back and argue at any of these working group consensus also, because there are so many varieties of constructs, and everything is not going to be the same for all the cancers, all the constructs, pediatric versus adults and things like that, right? And I told you already, the mainstay of treatment is going to be immune modulation or anti-inflammatory therapy. I'm really not going to go into the details, but this is broadly how you approach. You need to make a diagnosis. Is it a CRESS? Is it ICANS, or is it CRS, or is it HLH? HLH, fortunately for us, from whatever the reported trials, the incidence seems to be as low as 1%. That's all, the worst case centers. Okay, but by and large, it is CRS and the encephalopathy syndrome, plus the various other minor organ toxicities that we are all smart at handling. Okay, so you make a diagnosis, you grade them on their severity, and go ahead with a protocolized approach to treatment. So again, there are several organizations that have come up with their own grading system, which only subtly different from each other. Like, for example, I've put up a few examples over here. NCI is the National Cancer Institute, UPenn, that's a University of Pennsylvania and Children's Hospital of Philadelphia grading, or the more recent one is the American Society for Bone Marrow Transplant. In a nutshell, I mean, you don't have to, it's a noisy slide, you don't have to bother reading that. In a nutshell, grade 1 is just where they present with constitutional symptoms. They are slightly sick looking. They need a little bit of support. Grade 2 is when we start having the onset of hypotension, which is just about volume resuscitation, volume responsive. You have a little bit of hypoxia, which seems to be responding well with only low flow devices. Or grade 3, where we start having to use vasopressors, we start having to use high flow oxygen or higher FiO2s. And grade 4 is where we have extreme organ toxicities, and we land up with ventilation and other organ support systems. Okay, so that's basically the 1 to 4 classification. And treatment, again, let me put it in a nutshell. Grade 1 is all about symptomatic management, treat fever, treat anxiety, screen for infections. That's very important, because I told you already that sepsis is also something very notorious. Fever can be either because of the immune effect, or it can be because of sepsis, and you always have to rule one out. So screening for sepsis is extremely important at every stage. Once it starts getting a little more severe, grade 2 or grade 3, apart from the usual principles of critical care governing fluid therapies and oxygen therapy, the mainstay of treatment is going to be tocilizumab, which you can repeat up to 2 doses. We would like to keep corticosteroids for as late as possible. Reason being, corticosteroids are naturally going to blunt the effect of, see, this whole concept is an immune effector therapy. Okay, so you don't want to reduce the inflammatory cascade actually. So you want to see if you can handle this best with focused or targeted treatments, like by using anti-IL-6 or anti-IL-1, anti-IL-2, things like that. So in our armamentarium, we have tocilizumab, which is usually recommended by most of these guidelines as a first-line therapy. If that fails, you can think of cetuximab or anakinra. Again, I'm not going into details. It's when we go well beyond all this that we start thinking about corticosteroids, knowing very well that we are also going to reduce the effectiveness of CAR T cell therapy. Interestingly, it has been demonstrated that while you use tocilizumab or any of the other MABs, this sort of blunting of therapy doesn't happen. Okay, so that's basically it. And likewise, even for the encephalopathy syndrome, there is a grading starting off with only subtle alterations of sensorium, which progresses on to seizures. And in grade 4, you also have focal motor deficits. You identify them. The treatment strategy is also very similar. Grade 1 supportive, grade 2 TOSI plus or minus Cetux, grade 2 to 3 low dose corticosteroids, 3 to 4 higher dose corticosteroids, maybe even pulsing them with methylprednisolone, all those things, right? One thing that needs to be noted is tocilizumab doesn't cross blood-brain barrier, doesn't isn't too effective in isolated ICANS or CREST. But fortunately, we've seen that isolated ICANS or CREST is usually not the picture. It is usually along with CRS, and when you handle CRS, when CRS resolves itself, many of the times we also see that CREST comes down. Okay, so that's again the escalation matrix 2, 3. HLH also, I mean, intensivists are all experts at handling HLH, so we don't have to go into too much of this. This is very rare. From even centers that have done cross more than 300 CAR T therapies, the incidence is less than 1%. And yeah, that's almost my second last slide. So we have all these, what I put forth through you, the grade recommendations and the treatment recommendations are predominantly from MD Anderson, okay, from Dr. Neelapu's unit. But then once these guidelines have been published, and the rest of the society, especially pediatric oncologists and people practicing at other parts or using other constructs, lash back saying these guidelines cannot be a one-size-fits-all sort of an approach, which we all know. Okay, that's also how it happens in critical care most of the times. So these people, especially the pediatric people, feel that there is an overuse or overprescription for tocilizumab, overprescription for corticosteroids. You don't actually need to start them in grade 2. Maybe you need to reserve them for more severe grade 3 to grade 4. Likewise, they feel that we were being too paranoid in our screening principles. Like for example, Neelapu's unit, they recommend everyday bedside EEG in patients with the slightest alteration in sensorium to capture that NCSE when it happens. So there are subtle points that the rest of the world are lashing back at. So we still don't know which is the right way. If you're looking for an ideal way forward, that's probably not going to exist. We need to very soon generate our own data. I'm sure each one of us, while I was discussing with many people over here, looks like everyone is geared up for the next CAR T patient. So and with our AI falling in place, I think we should be having our own data very soon. Of course, there's a whole lot that we can keep discussing forever and ever, but I heard the first bell go already, so we're not talking all these things. A few interesting things, there are these bispecific antibodies also coming up, which are not the T cell constructs, but chimeric antibodies, which are capable of binding to the cancer cell and presenting them to the NK cells, the killer cells, right? Likewise, even allogenic CAR T cells are coming up. As of now, what is going on is a autologous patient's own cell. Allogenic is also coming up, and various other newer constructs are also on the pipeline, not just the anti-CD19 or CD22. So there's a big evolving role for CAR T cells, and I think within 5 years, we may even land up treating solid tumors with CAR T cells. You never know, right? So in summary, 2017 is where the FDA clearance comes, and we are not too late. We've already placed ourselves in the map, in the global map. We have our own construct. Many of our centers are gearing up, and I'm so too eager to see what happens. What is interesting is this is going to be a hardcore multidisciplinary concept, because people like the intensivists, the neurologists, maybe the ID specialists are going to be an integral part of this particular form of oncotherapy. So with that, I conclude. Thanks for your kind attention. I will be happy to take questions, although I make the same disclaimer again. I'm still to get experienced in this.
Yeah, but it was indeed very, very nice presentation on CAR T, covered almost all aspects. So it seems that you are having very good experience of having dealing with patients on CAR T, it seems from your talk. Any questions from the house? Basically, how to rule out sepsis in patients who are having CRS-like symptoms after CAR T or bispecific antibody therapies.
Yeah. So, one, how do you manage CRS? Of course, by and large, same principles. I think critical care is among the relatively easy specialty, because for everything, it's the same principle. Under CRS, you're going to have endothelial dysfunction again. You're going to have shock. There's going to be relative hypovolemia. There's going to be organ toxicity, organ dysfunction. So all of these follow the same principles of management. In case you're wondering if we use any specific drug therapies, by and large, it is supportive management. In CRS of COVID, of course, we did use a lot of tocilizumab. There are ambiguous data for and against all those things. Corticosteroids always come into question. Again, we don't have blanket guidelines or blanket statements given the individual reason why there is CRS. If you ask me how I manage CRS in CAR T cells, I'm yet to manage one, but I just showed you what is practiced at MD Anderson, which is also similar, just that the threshold for starting a drug therapy varies between centers. The pediatricians seem to be having the highest threshold because they also have a wonderful recovery rates from these complications, at least from whatever the literature that I could see. Adults probably, again, I showed you the mean age in St. Louis Hospital was 60 years. The mean age in MD Anderson is again in their 60s. So probably given all the comorbidities and additional problems, maybe, the chances or the outcomes are worse. So there is a role for earlier drug therapy. The next question, screening for sepsis, of course, it's cultures. Cultures are all high index of suspicion. Know which is likely to be your focus. Quite often there is this bad practice of pan cultures, which in desperation we do land up doing sometimes. Okay, but then I think everywhere we need to fit in clinical knowledge, bedside judgment. That's very important. Cultures is what I would largely insist on, although we keep talking about procalcitonin, CRP. These are going to be corroborative factors that help us in, like, adding more strength to our diagnosis, but nothing like microbiological diagnosis. And quite often in these patients, we do land up having to start on empiric therapy. So please make sure that cultures are drawn before the empiric therapy is started, and be very clear on your de-escalation principles. Again, in this sort of a sick patient, it's going to be a little tricky, but let's say in 2 days, if the culture comes negative, and by that time you also see the trend of improvement, you can definitely be safe enough to stop therapy. Okay, so de-escalation also needs to be kept in mind. Having said that, sepsis is quite common, to the tune of 30 to 40% average from whatever the literature that I could gather in patients post CAR T cell therapies. So there is going to be fine tweaking of all these guidelines, be it hypoxia management or fluid therapy or antibiotics. There is going to be fine tweaking for all patients who are immune compromised.
So I think many times we both sepsis and CRS together. Not that we can rule out sepsis. We have to give antibiotic, and same time we need to treat CRS also. Sir, I have a small question for you. Many institutes, they are doing both stem cell transplant and CAR T therapy together. What is the advantage of combining these two therapy together?
Basically, it all depends on the disease. I mean, if a patient is having a refractory B-ALL and you are planning to induce him with CAR T, so there's a induction regime. It can be chemotherapy or CAR T therapy. Once patient goes into a remission, then we have to consolidate it with the stem cell transplantation. So CAR Ts are various kinds of CAR Ts. Some CAR Ts are short-lasting. They do not sustain in circulation for more than few weeks. In such patients, post-CAR T responses are there, but the relapse rate is also very high. So to prevent those relapses, subsequent transplantation is advised in certain CAR T constructs, not in all, I think. What? So transplant is a different thing. I mean, CAR T definitely is a chimeric antigen receptor T cell which targets your cancer cells through a particular molecule. For example, in B-ALL, CD19 CAR T is there, CD22 CAR T is there. So that will target CD19 molecule on the cancer cells. But then post-CAR T relapses still can happen. So there is a escape. Relapse disease can have CD19 negative disease. So to prevent such kind of relapses, a transplant is advised when the patient is in complete remission. In such patient, transplant can give a chance of cure also, for long-term cure. But I have a question for you, sir. Is IL-6 level can help to differentiate between sepsis versus CRS in such patients?
No. So IL-6 is going to be elevated wherever we trigger the pro-inflammatory cascade. So it's not going to make an etiological classification.
Basically, to differentiate sepsis, we have to rely on our cultures. And we have to de-escalate as soon as we get the cultures negative, and then treat CRS.
Yes.
Any more questions from the house, Dr. You have a comment?
I'm very well tuned to St. Louis protocol, being from there, and even Fred Hutchinson Cancer Center where I was working. So for all the CRSs, we of course start antibiotics. We don't wait, but we de-escalate fast. But you have to also understand the sensitivity that you have. We had NGS online. Money was not an issue. We said NGS for everyone. There's nothing like culture. Within 3 hours, we get report. And you also have to know how that NGS is done. If it's very sensitive and you know that it's definitely not infection, then we de-escalate. So here I would be very careful on what we are doing. So it all depends on the lab support that you have and the sensitivities that you've developed. In St. Louis, you get report in 4 hours. At Fred Hutch, you get report in 2 hours. So I
agree.
I mean, it's better to have NGS-based detection of infectious agents rather than waiting for cultures. So with this, thank you very much,
Thank you.
Dr. Raymond. It was a really lucid talk, and thanks very much for the audience also.